Well, it's wonderful to be back here in Houston, where I've spent so much of my training periods, and to see so many friends who are here and collaborators. So, uh, my background is as a pediatric cardiologist, as you heard, and so my laboratory for many years has tried to understand how the heart is normally formed in utero, and tried to see if we could utilize that information both for understanding the basis for cardiac disease from a genetic standpoint and understand mechanisms and ultimately potentially therapeutics, as well as using the information of cardiogenesis for regenerative medicine purposes. And I'll tell you a few stories today in each of these different areas. And I know that we have a relatively broad-ranging audience, from hardcore scientists to clinicians to fellows and clinical trainees. So bear with me as I try to address each of the different populations. And so on the regenerative medicine front, which I'll address first, this is the problem that we're often dealing with. There are many reasons for heart failure, one of them being ischemic heart disease related to coronary occlusive events, where the damaged heart is left looking something like this, with scar tissue and loss of cardiomyocytes. And because of the limited or to no regenerative potential of the mammalian heart, this is what we're left with. And so there have been a number of efforts by many investigators, including some here, to introduce stem cell derived products into the heart for regenerative medicine. And in some cases, those are pluripotent stem cell derived cells that are actually beating cardiomyocytes to restore cardiomyocyte population. In other cases, those are other forms of adult stem cells that may have an immunomodulatory effect in this region for potential benefit. I'm going to talk about a different approach here that our lab started to take some years ago, which is to ask, can we get resident cells in the heart that are already there to do something that they don't normally do to try to create new muscle? And the two approaches we took are shown here. Either getting the existing cardiomyocytes that are remaining in the heart to re-enter the cell cycle and divide again to make more of themselves. And normally, as you probably recognize, soon after birth in humans, there's little to no capacity of these cardiomyocytes to divide, although there was capacity in utero. And the second is to get the fibroblast in the heart, of the scar-forming cells, to become reprogrammed into more cardiomyocyte-like cells to regenerate the heart from those cells within. Now, on this first topic, you all are fortunate to have Tamer Mohammed, who, while in my postdoctoral fellow in my lab many years ago, he figured out a cocktail of cell cycle regulators, indicated here, that together could efficiently coax adult cardiomyocytes to re-enter the cell cycle and divide, with about 15 to 20% of them undergoing cell division. And this was visualized both directly under the microscope, as well as with the rigorous genetic markers in vivo to demonstrate this. And these four cell cycle regulators, CDK4 and cyclin D, which affected the G1S transition, and CDK1 and cyclin B, which affect the G2M part of the cell cycle, together we're able to induce stable cardiac cell division. And when I say stable, I say that because if you remove one of these, then cells sometimes could divide, but they would immediately undergo mitotic catastrophe and kill themselves. And so they would die. But with this combination, it seemed fairly stable. And so Tamer is here now for the last year at Baylor and Texas Heart Institute, and doing beautiful work to try to advance this technology and understand it better and move it towards the clinic. And one approach he's taken is to use lentiviral delivery mechanisms to achieve this. But several years ago, we had tried to use a different technology where we delivered these with messenger RNA, because messenger RNA delivery is wonderful, except for the fact that it's only there for 48 to 72 hours and then it's gone. And that's a problem if you want sustained delivery of your genetic material, but it's perfect for this because one of our concerns with delivering these 4 factors with a longer term is that they could be oncogenic. And so the fact that mRNAs would only be present for 2 to 3 days was perfect for this. And so we had tried this years ago, even back in 2018 when Tamer published this paper. And at that time, we just couldn't get good delivery or expression with these. But fast forward a few years, COVID hit, and you all know that the mRNA that did work with delivery was packaged in lipid nanoparticles. And there had been a major advance in LNP technology that really allowed that. And so we revisited this recently and tried to ask, can we deliver mRNA for these 4 factors in a lipid nanoparticle? And it turns out that we can do that in a dish, but to do it in vivo, we still face the hurdle that there weren't good lipid nanoparticles available that could have tropism to the heart. And so we engaged on a collaboration with Niran Murthy and Kevin Healy at UC Berkeley, who were making panels of LNPs, and we screened for those that might have greater tropism for cardiomyocytes. And I'm just going to show you one video of an LNP that we found that actually does penetrate cardiac muscle quite well and with a better ratio than typical LNPs compared to the liver, where most of these LNPs usually go. And so what you're seeing here is a heart, a mouse heart, where we've systemically injected a Cree mRNA with a reporter that would make cells that took up the mRNA look red. And you can see here, if we penetrate, this heart had a coronary occlusive event. So this area that's highly red is the ischemic part. And you can see as you delve deeper, there's these large cells that are cardiomyocytes and also smaller cells that are largely fibroblast and macrophages. So we're getting the major cell types are all being hit here in this heart, and particularly in the area that we'd want to address, which is ischemic. So this is a systemic injection, yet you can see we're getting an accumulation in the area of interest that's undergone this ischemic insult. So we're now utilizing this LNP to deliver these 4 factors, cell cycle regulators. We're also collaborating with Jim Martin's lab, who's also here at Baylor and Texas Heart, to deliver his beautiful work regulating hippo signaling with the protein YAP to get cardiomyocytes to divide that way. And we're very hopeful that one of these 2 methods will work. So that's still in development, but I think this is an approach that I think has legs to try to get these cells to divide in a transient manner. The other approach that I alluded to is to harness the other major cell type in the heart, which is fibroblasts, which make up 50% of the cells in the heart, where we asked, can we get these fibroblasts that are already in the heart to convert themselves into cardiomyocyte-like cells? And we've published a body of literature in this area, and Tamer also did some beautiful work on refining this technology. And I'm just going to show you one slide summarizing that body of literature over many years. And that is that a combination of 3 developmental cardiac transcription factors together were sufficient in vitro and to greater extent in vivo to move cardiac fibroblasts to be more like cardiac muscle cells. And each of these 3 factors are essential for normal development of the heart in an embryo. And 2 of the 3, in fact, are, when mutated, we know cause congenital heart defects. And in mice, pigs, and also in rats, when we introduce these 3 factors with the viral vector, we're able to convert cells to be more like adult ventricular cardiomyocytes. These cells electrically couple with their neighbors, and they can improve cardiac output by MRI. And many years ago, then, we put this technology into a startup company that we called Tenaya Therapeutics that's raised a good amount of money over the years to try to take this to the clinic. And they've modified our approach to get less genetic material that can fit into a single adeno-associated virus which can only hold about 5 kilobases. And they've taken that product and done a preclinical study in pigs with a pig heart here. Looks very similar to an adult human heart. And you can see here this area with after a coronary occlusive event by ballooning the coronary artery causes blanching here and damage at the apex. And they have introduced their cocktail with an AAV with an extracardiac injection through the thoracotomy into this area, and done that about a month after an infarct, creating an infarct. And what I'm showing you here is some results from Tenaya, where you're looking at the absolute change in ejection fraction on the y-axis 4 weeks after an MI. So now the damage has stabilized, and we're graphing here is over time the change in ejection fraction, either with placebo or with the therapeutic agent. And you can see here after about 2 months, we're getting on average with the group of about 10 pigs, an 11% improvement in ejection fraction. And these started off, the average baseline started off at about 30% EF, down from about 50 to 55 in a normal pig. And so it's about a 33% relative increase, and this is pretty promising. But the extracardiac injection is probably not a viable clinical approach. And so Tenaya has worked to develop a new catheter for intracardiac injection. And fortunately for us, Dr. Perrin here at Texas Heart collaborated with Tenaya to try to use this catheter in a preclinical pig trial. That trial looks like with this new catheter is not showing this type of efficacy. But that catheter has, according to Dr. Perrin, has had some difficulty. And so we're trying to see now if that is due to technical difficulties of delivery, which may be the case, or if that cocktail just doesn't work through that intracardiac injection route. And so that's still ongoing before this can advance towards a clinical trial. So one approach that I've shared with you then is trying to get these cardiomyocytes to either regenerate or fibroblasts to become cardiomyocytes. But we also know that that during heart failure, there's a steady decline in cardiac function over time that's related to fibrosis that occurs in any stressed heart. And that relates to these fibroblasts getting activated and laying down more collagen and fibrotic tissue that then makes cardiac function worse. And so I want to share with you a story led by Mikhail Alexanian, a very talented postdoc who now is running his own laboratory at Gladstone, that's related to this fibroblast activation and fibrosis. And this story started with the observation from one of our Gladstone investigators who now is leading a discovery effort at Amgen, where he had demonstrated that there's a group of regulatory proteins that control gene expression known as BET proteins. And these are proteins that go and bind to gene regulatory areas on the genome. And under conditions of stress, cardiac stress, be it ischemia or pressure overload, these accumulate at specifically at what we call stress-activated enhancers and turn on a battery of genes throughout the genome that are all maladaptive and actually are the ones that make the cardiac function even worse over time. And Sap Halder, who did this work, had found that using a small molecule drug that would effectively remove these BET proteins from these enhancers could alleviate activation of these stress-dependent genes and improve cardiac function. And this turns out, interestingly, to be a highly reversible process. And what I'm showing you here is the ejection fraction, again, on the y-axis, days after thoracic aortic constriction, where we increase pressure load on the left ventricle. And you can see here in mice, without any treatment, the function declines. And if you don't do anything, it declines further over time. However, if you give this JQ1 drug in blue, then function improves almost back to normal within a period of time. But then if you remove this drug from the mice, then function decreases again. And here, not shown, you can add back the drug, function will go back up, and you can basically toggle this back and forth. which means it's a highly reversible process. And what Mickey did in my lab was then to take these hearts at each of these stages and do single cell analyses where you can digest the heart and take thousands of cells and analyze what is going on in every cell at the RNA level and at the epigenetic level, looking at chromatin. And I'm going to share schematically what the conclusions that he made by doing this study a couple of years ago that we published back in 2021. And what Mickey found is that these BET proteins actually act on a very important gene called MEOX1 that we found essentially serves as, you can think of it as a transcriptional switch, if you will, for taking fibroblasts from a quiescent state into an activated state that now lays down fibrotic tissue. And these BET proteins activate MEOX1, and then that leads to fibroblast activation. And MEOX1 is a type of protein that goes and binds thousands of other genes and turns them on and off. And in fact, it binds lots and lots of pro-fibrotic genes across the genome and activates them and leads to fibrosis. And so that was great. This was a key sort of master regulator, if you will, of the response to stress that results in activation of fibroblast in the heart and fibrosis. And I should say that the same gene looks like it's a master regulator in lung, fibrosis, kidney, and liver. So we think in fibroblasts throughout the body that this is playing that central role in fibrotic disease and may be a good target for in each of those cases. Now, specifically for the heart, the next question that Mickey and his close collaborator, Arun Padmanabhan, who's a cardiology fellow now attending at UCSF, asked is, how is it that the heart senses this stress to result in activation of fibroblast and MEOX1? Because somehow there has to be a connection to this stress that's being sensed to this situation. And so they went back to this, the data that I mentioned earlier, where we have these conditions where we've created stress with pressure overload, treated, and then withdrawn, and looked at genes that were altered either up or down at the expression level of RNA. And if you plot these, as I alluded to earlier, the cell type that's most commonly affected is fibroblasts, where there are lots of genes that go up and down with this. But the second most highest group of cells were myeloid cells, so macrophages and things related to the immune system. And so if you just look at those cells, because we've done single cell analyses for all these, so we could just pull out the myeloid cells, immune cells, and ask a similar question, is what genes are correlated in a way that when ejection fraction goes down and the heart's more stressed, do the expression of those go up? And when ejection fraction goes down, which genes go down with those? And there are a number of interesting genes that correlated positively or negatively with cardiac function, but one of those really stood out to us, and that's a gene called CX3CR1. And the name's not important, but the reason it's interesting is that this is related to a cytokine pathway that is coming from the immune system, specifically from macrophages in the heart. And there are two kinds of macrophages: resident macrophages that you're born with, and ones that are circulating that come in from the blood. And data I won't go through with you, we had reason to think that it's these circulating macrophages where this gene is important. So the question becomes then, is the inhibition of these BET proteins in this specific cell type meaningful or not? And there's a way genetically we can do that, where we can delete one of the important BET proteins called BRD4, specifically in cells that are expressing this marker CX3CR4. So these are specifically deleting this BET protein only in these immune cells, not in the fibroblast, not in the myocytes or any other cell type in the heart. And then we can ask, does that affect cardiac function also? And those are the results I'm showing you here, where here, again, we're looking at ejection fraction on the y-axis. In red are the control mice where we have not deleted this protein, and blue is where we've deleted it. And this is at baseline. Ejection fraction's up here around 60%. And then you can see a month after creating stress, the control mice have a decrease in function. And that decrease in function is partially reversed by deleting BRD4 just in these immune cells, not in fibroblast or any other cell type. And so we then took these hearts and again looked at their individual cells and looked at what RNA levels were up or down, and in all the different cell types. And what we found is that, as we'd expect in the myeloid cells, there was a big difference in the individual cells under control or settings where we've deleted this one gene. And what you're seeing here is a plot where it's hard to see. There are lots of different dots in here, each dot representing a different cell. And they clustered it based on how similar they are. And so among the myeloid cells in orange are the control cells, and you see most of the blue cells are separated in space in this plot from the orange cells, which means they're different. But we would expect that because we made a change in these myeloid cells by deleting this one gene. But what is surprising is in fibroblast, the orange and blue cells also completely separate, which means that they're intrinsically different, even though we didn't do anything genetically to the fibroblast. And that suggests that somehow by altering these myeloid cells, there's a secondary impact on fibroblasts. And you can see here the number of genes that are changed here. And so what that suggested to us is that when we remove this BET protein from these myeloid cells, we affect the fibroblasts somehow, and they get activated. I'm not showing you many of the genes that were altered are ones that are typical of an activated fibroblast, like what I showed you before, that lays down fibrosis. So that suggests that there must be something secreted from these myeloid cells into the fibroblast that then results in their activation. So we went back to that same gene expression data in the plot that I showed you earlier, and we asked, are there any secreted factors that are altered, that genes that encode for secreted factors that are altered, and are there ones that go up in their level in stress and go down with the chemical treatment or with deleting BRD4 in just these cells? And that's what this plot looks like. And one of the proteins that really stood out is interleukin-1 beta, which is way up here as a gene that's a secreted factor. When the ejection fraction goes down, its expression goes way up. And so this seemed like a reasonable candidate protein that is secreted from the macrophages and that might be affecting the fibroblast. And so there's a way we can experimentally test that. There's actually a commercially available interleukin-1 beta antibody that binds to the interleukin-1 beta and neutralizes it. And so we can treat mice after a thoracic aortic constriction with this antibody, and then ask, if you block interleukin-1 beta, do you now block fibroblast activation and improve cardiac function? And so we did this, treated them for a month, did echoes, and then looked at their individual cells. And so first I'm showing you here what happens to the ejection fraction. And here in red is the decrease we would expect in ejection fraction in mice treated with a control antibody. And then here in blue, you can see there's a partial, not complete, but partial recovery of function with using this interleukin-1 beta antibody. And we think that there are other secreted factors that we have identified in this analysis that also are likely playing an important role. But clearly, interleukin-1 beta inhibition is improving cardiac function. And so then we can look at what is the effect of this on fibroblasts, if that is indeed a signal coming that's affecting activation of fibroblast. And what we found both in the mouse hearts, there was less fibrosis. And when we look at this type of plot again, where here in orange you have single cells that were from hearts that were stressed, but treated with the control antibody. They cluster in this space. And in blue here, after treatment, you see they cluster separately. Again, just the fibroblast. And if you look at where this transcriptional switch that I mentioned earlier of an activated fibroblast, MEOX1, you see blue means that it's a higher level expression. And you can see here in the control setting, under stress, there's a lot of expression of this master sort of switch of the activated fibroblast. But look over here, upon treatment with the antibody, interleukin-1 antibody, now you see this MEOX1 level goes down in the fibroblast, meaning these never really get activated. And so what we think is happening is that under stress, the macrophages or myeloid cells that are expressing this marker are actually the ones that are sensing the stress. And we've mapped out with quite high level of detail exactly how that happens and how interleukin-1 beta gets activated by these BET proteins, gets secreted, and this message is then received by a specific regulatory region in front of MEOX1, and then MEOX1 gets activated and causes fibrosis and worsens heart failure. And the beauty of this is it creates multiple targets for potential intervention, either like I showed you at the secreted stage, but even by regulating this protein, regulating an enhancer of it. And so we are now, Mickey in his own lab is working on ways to intervene that could be therapeutically relevant. So those are the stories I wanted to share with you related to both cardiac regeneration and affecting cardiac function. I want to, in the last part of the talk, share with you a story related to the genetics of human disease and how we can utilize genetic knowledge to understand mechanism and then ultimately derive new therapeutic approaches. And I'll share with you, our lab has published a body of literature in this topic, in this area over the years, but I wanted to share just one story with you that has been perhaps one of the most satisfying arcs of investigation of my career that really goes all the way from taking care of a patient to a potential therapeutic. And that is related to the disease shown here, where the aortic valve in the heart often gets calcified in an age-dependent fashion. And with these calcium deposits, the aortic leaflets don't open and close very well and ultimately need to be either surgically replaced or replaced with open heart surgery or with a catheter-mediated intervention. This is a very common disease. It's the third leading cause of adult forms of heart disease, and as I mentioned, it's age-dependent. Now, there's a congenital anomaly that is a condition that is very, very common, where 1 to 2% of the whole population worldwide is born with an aortic valve that looks like this, where instead of the normal 3 leaflets that form this nice Mercedes sign, these children are born with only 2 leaflets. So we call this a bicuspid aortic valve. And for reasons we've never really understood, these children with these kind of valves are often completely normal at birth. They don't even know they have it. But as they get older in their 3rd, 4th, 5th decades of life, they have a very high incidence of calcification. About a third of them will go on to get calcified and need a replacement. And so many years ago, now 20 years ago, actually, a little over 20 years ago, when I was at UT Southwestern in Dallas, I took care of this little boy here at the bottom of this family tree when he was only a few weeks old. Me being a pediatric cardiologist, I saw him because his aortic valve was really thick and wasn't opening and closing even as a newborn. And he needed a catheter placed across it and a balloon inflated to open it up for him to survive, which he did. But when taking a family history, it became clear that there are many generations of individuals in this family that when they're 20, 30, 40, needed to have open heart surgery to have a calcified aortic valve replaced with a mechanical valve or PIG valve. And so this was clearly an autosomal dominant transmission of a single gene that's causing this. And so back then we were able to map this to find the single gene mutation that was causing this. And it turned out to be caused by a heterozygous mutation in a very important gene called Notch1 that is of that type that will go and bind to DNA and turn on and off thousands of other genes. So another master regulator, kind of like MEOX1 was, but now with a different purpose. And since then, we and others have found this mutation in many, many families with aortic valve disease. And so that was great. It was our first known genetic cause of this common type of disease. But it turns out that, it doesn't really help you to know the genetics of a disease if you can't get to the next step, which is understanding the mechanism by which that mutation causes a disease. And what we do normally to figure out mechanism is go to a mouse model or an animal model and make the same mutation and study it there, because it's hard to study in humans. So we did that, and we made mice, or looked at mice with this mutation that were heterozygous, and they're completely fine. They had no trouble at all. And mice that were homozygous, null, died early as embryos because Notch is also important in the whole vasculature, and they didn't develop vessels and they died. And so we were stuck for many years. We didn't really learn anything, and we moved on and studied other things because there was really no tractable way to figure this out. So that was pretty unsatisfying until my colleague at the Gladstone Institute, Shinya Yamanaka, invented a way to take adult human cells from patients and in a dish reprogram them to become just like their embryonic stem cell equivalents that he called induced pluripotent stem cells, or iPS cells. And these have the property that you can then turn them into any cell type you want in the human body. Well, that gave us the opportunity to take the cells from these adults from this family and make their own pluripotent stem cells and then turn them into endothelial cells in the dish, which we had other reasons to believe is the endothelial lining of the valve that was where this gene was important. So we did that. We called, by this time I had moved to San Francisco, we called lots of the family, flew them up to San Francisco. We made iPS cells from 4 people with the mutation in the family, 4 people without them. We spent several years at that time trying to make endothelial cells, which wasn't trivial. We figured out how to do that. And then we looked at those cells, interrogated them. And after all of that, which probably took 4 or 5 years, we learned absolutely nothing. And the reason was, yes, the family members with and without the Notch mutation were different there, but they also had millions of other ways they were different in their genomes. And so there was just too much noise in the system to really ferret out what was this mutation was causing in these cells. And so that was frustrating again. And it wasn't until then Jennifer Doudna, who invented the ability to do gene editing, and now she also runs a lab at Gladstone, but didn't at that time, that allowed us to use gene editing to go into these iPS cells and just change the one nucleotide that was altered in the patient's lines and normalize the Notch in those. And now we had cells that we could look at that had the Notch mutation and those that didn't, and everything else in the genome was exactly the same. And when we did that, then all of the biology laid itself out beautifully, and we figured it out. And this was work led by Christina Theodoris, who was an MD PhD student at that time in the lab. And she published this work now many years ago, where she had interrogated these cells, made billions of them, and looked at where does Notch bind to DNA, how does it affect the epigenetics and the RNA in this. And what she found was really rather simple. And that is that the crux of this disease is that the valve cells get confused and they start to think that they're osteoblast-like cells. And they do what a good osteoblast should do, which is lay down calcium. And so it's really essentially a cellular reprogramming event that happens endogenously where these cells change their fate right in the valve and become more like bone. And so you might ask, why would this be happening? And why is Notch important to keep that from happening? So Notch's job, basically, in our valves is to stop this event from happening. Why? And it turns out that it's quite interesting, is that nature has used the same sort of genetic machinery and pathways to make valve tissue in the heart as it does to make cartilage. And you can think valves are kind of fibrous tissue like cartilage that share some similarities. And so the body has used cartilage pathways to make valves, but then it has put notch there to say, okay, stop, don't now become bone. And basically that's what it is. And so in setting where you reduce the amount of notch, now you reduce this brakes on this system, and these over time, these cells become more osteoblast-like. That's the disease. Christina was able to map out not only this feature, but deeply a gene network switch and exactly how that sulfate switch occurs. And she found that the upregulation of just 3 other master regulators, the names aren't important, 3 other master regulators, when they go up during this process, that accounts for about 80% of all the 1,000 genes, let's say, that change, leading to this sulfate switch. And because of that knowledge, she then designed, based on that, a small molecule drug screen to ask, can I administer a drug that would stop this sulfate transition? And basically, all we have to do is stop these 3 from going up, and that would stop everything. And so she did that sort of screen, and lo and behold, found a small molecule that looks like this, that was very effective in stopping these genes and the whole network from switching, and then ultimately this switch from occurring. It's not important for today's talk, but this molecule, we now know, targets a nuclear hormone receptor called estrogen receptor-related alpha, that we know what its target is. And so now this is great. We have a drug that works in these human cells in a dish and could be a really good drug, but that's not going to go directly into a clinical trial, of course. And so we needed to have some way to test this in an animal model. Well, I think I told you at the beginning of this story that the mice that are heterozygous for Notch are normal. And so that was a problem. So we didn't really have a good model. Christina had the clever idea that since this is an age-dependent disease, and she knew that mice have much longer telomeres than humans, that maybe mice are protected simply because their telomeres are longer. So we know telomeres are associated with aging. And so I won't go into the details, but she made a mouse model where she shortened the telomeres. And just by shortening the telomeres a little bit, these mice completely recapitulated the human disease state. It's really quite remarkable, and I'll show you that here. This, on the upper panels, are mice that are normal for Notch and have a little bit shortened telomeres. And this is a cross-section through the aortic valve region where you can see these nice 3 thin leaflets that are not calcified, with calcium being marked in red. And this is a close-up. And here, if you remove 1 copy of Notch from mice in the setting of shortened telomeres, you get these thickened aortic valve leaflets that are heavily calcified. So this is just like the human disease. And this happens within a month or 2 after birth, so really rapidly. And so now we have a model for this, and we could also go back and ask in vivo in mice, are these really more like osteoblasts or bone cells? And there's a marker that's commonly used for osteoblast, shown in green here, and we can ask, do these cells here, or do they turn on this marker of osteoblast, which you can see here they do. And so we really think this is a sulfate switch. But more importantly, this gave us an animal model to ask whether this drug actually works. So we did echoes on these mice to see, can we detect aortic valve stenosis by ultrasound just like we do in humans? And what you're seeing here is measurement of the aortic valve peak velocity of flow across the valve. So if the valve gets narrowed and the same amount of blood has to flow across it, the only way it works is if it has to flow faster. And that's what we measure in humans also by ultrasound. And we follow them by echo. And here you can see it's incompletely penetrant, but about 15 to 20% of the mice have aortic valve stenosis we can measure by ultrasound. About half have calcification, but only about 15 to 20% get it severe enough where we can see it by ultrasound and track it in a live mouse. And the pulmonary valve in these mice also are affected, and that sometimes happens in humans. So we took these mice then and we put them on drug in the first instance in a preventive fashion, even before they got disease. And what we found is that this drug prevented this disease from taking hold both in the pulmonary valve and in the aortic valve quite effectively. So that was encouraging. But of course, in humans, the clinical trial would not be prevention likely. It would be once somebody comes to the doctor, we can hear that they have a murmur, they get an ultrasound, we know that they have stenosis. Right now, all we do is we watch them over time. We have them come back every few years, do another ultrasound. When it's bad enough, then we'd make an intervention because there's no pharmacologic therapy today for this condition. So we try to do that kind of trial in mice where we try to ask, could mice be treated even after disease has set in? And if all we did was to slow down progression in humans, that would be enough. People often get this as they get older. They would ultimately die from other problems and not this. And so all we'd have to really do is slow down progression. So what we did is we took mice, we screened them by ultrasound, isolated those that have aortic valve stenosis by echo. And then we randomized in a double-blind fashion those mice to either a control arm or a drug arm. And we treated them for a month and then came back and did echoes again and asked, what's the progression of disease over those 30 days? So what I'm showing you here now as a result of this, we did about 25, 26 mice in each group. And what you're seeing here is the change in the aortic valve stenosis, or pressure difference, or velocity here on the y-axis over that 1 month time. So every mouse starts off at, let's say, 0. And what you're seeing here is the majority of these mice progressed in their degree of stenosis over time. Some, over 200%, but on average, 80 to 100%. So in contrast, this is really quite striking, the mice that were treated look like this, where the vast majority didn't progress much at all, and half of them, even regressed and had a decrease in their degree of stenosis, which we actually didn't even expect necessarily to happen. But this is, shows a really high level of efficacy in slowing down and even stopping or even regressing disease that's already taken hold. And so we're very excited about this potentially being able to work in humans and advancing this towards a clinical trial. Now, towards the last thing I want to show you is that everything I've shown you so far has been in the setting of a notch mutation, either with human cells or this mouse model. But what I didn't tell you is the majority of people are not going to have this disease because of a notch mutation in that, like families like that. They're just going to happen with no known obvious genetic cause. But you'll recall we didn't screen for a drug that affected the levels of notch. We screened for a drug that affected the whole network that would shift a cell to become more bone-like. And we think the reason we did that is we hypothesized that no matter what the insult, what the genetic basis, that the fundamental shift of a valve cell to an osteoblast cell would be the same, no matter what the cause of disease. And so if we're blocking that this drug might block this switch no matter what the inciting cause. And so we were able to test that in part by doing the following. When people have their aortic valve replaced, then the surgeons take that valve out and they throw it away. But we could not throw it away, but harvest the endothelial cells from those valves and grow them in a dish. And so we collected, in collaboration with a collaborator actually in Russia who had been doing this, they had collected a number of primary endothelial cells from human valves, either normal ones or calcified 3-leaflet valves or calcified 2-leaflet valves. And now we can ask, in these cells, is a similar gene network shifted, and are these 3 master regulators also up? And the fact was that we found that in all of these, no matter what, none of these had notch mutations. These were all elevated, and the same network was shifted. And then we can ask, of course, then, with this same drug, what happens? Does it restore this back to normal? And in fact, that was the case. Without showing you all the data that was published, this drug lowers that level also. And so with that knowledge, we think we're ready now to advance this to a clinical trial, even for garden variety sporadic aortic valve disease. And, you know, this can make a very significant impact because, as I mentioned, this is a very common disease. Right now, there's no pharmacological treatment. And our hope is that someday there would be an oral drug that one could take to really just slow this down or even stop it in its tracks. Now, I'll make one final comment is that the drug that I showed you, although it works really well, and it actually has good drug properties, it is going to be off patent in a few years. And so it turns out that we have not been able to get any venture capitalists, even though I sit in the middle of the VC world and I've started a couple of companies, to take this drug and spend about $20 million it'll cost to do this trial because they can't protect it afterwards. And so we've gone back to the drawing board. In the last 2 years, we have made chemical modifications to that drug and found a drug that's actually even better and is a novel drug that can be covered by a patent. Not that we care about it. I'd rather a cheaper drug be available and sold, but the trial will never happen with that. And so now we have a drug that looks really good drug-like properties, is novel. I think we'll be able to gain venture investment for this to take it to a clinical trial, and then we'll know the answer if this really works. But what I hope you can appreciate is that this has taken 20 years, in part because the technology just wasn't ready for it at every stage. If I saw that kid today, I think we could get to this point in 3 to 4 years. But it took persistence, technology to catch up, but to ultimately be able to go from taking care of a patient to having a drug that could work in the clinic, for at least for physician scientists like myself, is the ultimate dream. So what I've tried to share with you today is how our laboratory is trying to take advantage of our knowledge of developmental biology, both for regenerative medicine purposes and also understanding the genetics of human disease and developing therapeutics. We've got a really wonderful lab, current lab members, a number of great former laboratory members, as I mentioned, Tamara, who is here now, great collaborators here, both at Gladstone and also here with Jim Martin. We're using that LNP to see if we can stimulate cardiomyocyte proliferation with the beautiful technology that Jim discovered around hippo signaling, and we're doing that together. And this is just a picture of my current laboratory, which is a great group of scientists and physicians. And with that, I'll stop and be happy to take any questions if you have time. Thank you.